My name is Crystal Asige. I am a musician. I also have a YouTube channel. It's called Blind Girl Manenos, where I basically vlog and tell stories about what it is like to be a blind woman in Kenya. I'm also a public speaker at different events around the city and different parts of Kenya. Also very important to me is the work that I do in advocacy for persons with disabilities in the country. My condition is glaucoma, specifically juvenile glaucoma. In my own case, I never knew what glaucoma was before I actually was diagnosed with it. I had never heard of the word. I had never experienced anyone with anything like that. So being educated just through normal media channels and platforms, I think it'll be really good for the general public to understand, what are the symptoms. In Mombasa, Lighthouse for Christ is where I go. In Nairobi, I now see Dr. Masila at Kikuyu. And I used to as well travel actually all the way to Kisii to see Dr. Kiagi at some point before I now moved to Nairobi and settled with Kikuyu and Dr. Masila. One thing I discovered since having glaucoma and going through this, over almost 2-decade-long journey is that glaucoma specialists are very few and far between. I'm not sure the reason for that. I'm sure that, you as specialists can inform me better than I can inform you. But finding specialists in your city or in your hometown is kind of hard. And so those appointments, those consultations, the treatments, the surgeries, they have to always wait for a particular date when there is a specialist available. The first thing that they did give me was a gadget whereby you placed it just above your eye, and then it's sort of like a funnel whereby you put the drop in that gadget, and then it sort of funnels and puts make sure the drop goes into the eye directly. I think OSK and other ophthalmology societies and organizations in the country could do a bit more work or try to help people with blindness or visual impairment in several ways. Number one, I think the most important is to work with NHIF to get coverage for these kinds of conditions, because right now NHIF do not cover eye conditions like mine, which makes it so much harder to get treatment, to feel like you have enough money to afford medication and to afford consultations, because those are very expensive, especially because I have to have these consultations, for example, every 3 months nowadays. That's number one. Number two, I think another thing that can be looked into is appointments. When you go to appointments, the lines are super long. The consultation takes it's just a generally very long process. It takes at least your entire morning, if you're lucky, that is, if you're lucky to leave before lunchtime. So I think that maybe digitizing it would be great. For example, when you check in, you're able to check into a flight 48 hours before you actually get onto your flight. Why can't it be the same way? Digitize it so that I can go online on some sort of application or some sort of a website and, punch in my details, pay online or pay through M-Pesa. And then by the time I get to the hospital, I don't have to wait for so long, because it's generally really hard to A, find someone to take me there, and then B, it's a stressful period. Another thing would be social workers, people who can actually come to your house and give you individualized assistance, teach you how to live alone, and teach you how to get on safely in your own company, things like that, so that you don't have to rely on family or friends to assist you, even with the smallest things. I think that is both empowering, and also it helps you become a more functional citizen of your country, of your nation, so that you can actually go out and be productive. One thing I would like to add, which is specifically to clinicians and practitioners and ophthalmologists like yourselves watching, is please try and be more empathetic with patients. We're not just people with conditions who are just clients coming in for a 15-minute consultation. We are actually human beings. We have lives, we have feelings, we have emotions, we have ambitions and disappointments and all the rest of that which is in the spectrum. Another thing I would say is, let's not continue having too many meetings. Let's not continue talking about what needs to be changed. Let's actually just start changing things, because there are people who are blind and visually impaired that are suffering right now. As this conference is going on, as I'm speaking right this moment, we are suffering and we are going through all the hardships that I've just mentioned and way more. I also think that there should be more support groups around the country, in all counties actually, that people could go to and meet other blind or visually impaired people like themselves going through similar experiences. They can exchange ideas and, confide in each other and comfort each other, because this is, especially when it's a lifelong condition like mine, glaucoma, it's not easy to go through on your own. And I started a support group back in Lighthouse for Christ. It's called Lighthouse VIPs, visually impaired persons, and that really helped a lot of people who came. We had about 20 people coming to that. Again, my name is Crystal Asige, and I really appreciate the opportunity to speak to you as ophthalmologists and optometrists in the country. And I really do believe that what you're doing is a fantastic work, and things like this conference, and bringing minds together which are like-minded and trying to reach a common goal of making our lives easier as blind and visually impaired community. I think it's a fantastic thing.
I wish to thank the organizers of this OSK virtual conference for November 2020 for giving me an opportunity to share about the Kenya National Glaucoma Guidelines. My name is Dr. Dan Kiage. I'm a glaucoma specialist from Kisii Hospital in Kisii County. As you're aware, these glaucoma guidelines were adopted from the COEXA glaucoma guidelines, which had been put up as way back as 2014. And this was basically done by the glaucoma community of COEXA. And the participants then are the ones appearing here. That was myself. Dr. Gichangi has been with us all along. And there's Dr. Abeba from Ethiopia, Dr. Nima from Dar es Salaam. There's the ever-smiling Shira here, and there's Dr. Hiko, who was at that time in Tanzania. And there's this team here which now adopted these guidelines to what we have now, the Kenyan guidelines. They did a very good job, and allow me please to mention their names. This is Dr. Gichangi, myself, Dr. Shira Mako, Dr. Faith Masila. I've put her in a different color there because she participated more in writing them. Dr. Irene Makite, Dr. Nyawira also participated in actual writing. Dr. Nyaga Jr., Dr. Musyoki, Dr. Helen Roberts, Mr. Jojo Hito, Catherine Waiwe from KMTC, Sahara Rashid, Dr. Judy Ndirito, Dr. Steve Mukiri, Dr. Cynthia Wundo, Dr. Frederick Oril, and Dr. Sarah Stati. And so this is the team which has worked so hard in making what we have now. There were also external reviewers, as Dr. Andrew White from Australia, Dr. Karim Damji from Canada, and Dr. Bruce James from United Kingdom. So why glaucoma guidelines for Kenya? I mean, there are guidelines from everywhere. The America guidelines, a lot of European guidelines, South Africa, from Asian countries, a lot of guidelines everywhere. But you know that Africa or Kenya, we have a special situation. Our preference from glaucoma is very high. And so studies have shown that we have as high as 4 to 5 individuals, 4 to 5% individuals who have glaucoma in the age of over 40 years old. And that is compared to about 1 to 2 in the Caucasian population, 1 to 2%. Then we have this unique presentation of glaucoma in Africa, which you all know. The age of onset is usually much lower. They present when it's already very advanced. And there are all these anatomical peculiarities in the corneal thickness, in the features of the disc. So these are all things which are so peculiar that we have to have our own guidelines because our glaucoma here may not be the same as the one we see in other guidelines. Then there's this issue of the human resource for eye health. Who is diagnosing and treating glaucoma in Kenya? As opposed in other countries where glaucoma would be diagnosed and treated by glaucoma specialists, for us here, we have people as juniors, ophthalmic nurses, ophthalmic officers, general ophthalmologists, who are treating glaucoma. We have so far only 3 to 4 glaucoma specialists, and obviously they only see a small percentage of the people with glaucoma. So the guidelines have to be made in such a way that they can be used by the entire spectrum of the eye health specialists who deal with glaucoma. Then the other guidelines, of course, will show all the big machines which do diagnosis, the drugs that are used, the big machines that do surgeries and lasers. But that's not the same case here. We have an issue of affordability for the eye care services in this country. And even the availability of those diagnostics, the treatments, options, the drugs, is an issue. So our guidelines have to address this particular issue so that they can be useful to the people in Kenya. But we have tried to make these guidelines very easy, straightforward. And if you look at the table of contents there, it's nothing too strange. It's describing a bit of what glaucoma is so that we remind ourselves and we're on the same page. And then it's initial to talk about the initial and follow-up assessment. This is quite key. So we have made sure that it's indicated there so clearly so that we can all be doing the same thing. Then the treatment of glaucoma. And then we have talked about how should these guidelines be implemented. And there are some appendices there, which will be very useful information. So in the management, that is the assessment and the treatment. So we have, in the initial follow-up management, we have stressed on the history. What kind of history should you be taking? How can it be standardized so that people ask the same questions so that we get the same answers? What is intraocular pressure? How do you take it and what is its significance? How do you do gonioscopy? This is something we have stressed because it's been clear that a lot of units don't do this, but we have tried to explain how it's done, how to interpret what you see, because ideally there should be no glaucoma being diagnosed before gonioscopy is done. After all, we should be talking about glaucomas. If you say that these patients have primary open angle glaucoma, you can only do that if you have done a gonioscopy and ascertain that the angle is indeed open. It's very, very key to talk about the optic nerve head exam, because after all, this is an optic neuropathy. So what gets seen as having been damaged is the optic nerve. So it's indeed very, very key that we all know how to examine the optic nerve head and how to interpret what you see. Of course, we also talk about perimetry, the visual fields. We know that it may not be very, very key. You can still treat a patient without using a visual field, but it's important that if your unit has a visual field or you try to buy one, and then you should be able to know how to use it and be able to know how to interpret the results. In the treatment, we are not reinventing the wheel. We are not creating another treatments that don't exist. We still talk about drugs, we talk about laser, and we talk about surgery. And that's what has been covered in these guidelines. So we have spent time talking about the implementation of this. At the moment, these guidelines is really owned by the ophthalmic service unit, where Dr. Gichangi heads. And so they are the ones at the moment who charged with the responsibility of coordinating with the Ministry of Health, various counties, the NGOs, OSK, and the private practitioner, and then other players in this, so that we can be able to move forward and implement these guidelines. We need to disseminate it through the talks, like what we are doing now. We need to have it in soft copies and hard copies. And as I'm going to explain a little below, I'm requesting also if you can make these hard copies to be not in PDF, but in a way where you can, pick, copy, and paste somewhere. So because some of the things which have the tables which have been presented there are tables which need to be used practically. So if they can be picked from there and be pasted in the clinic, in various procedure rooms, that would be very appreciated. Training is very key because some of these issues we have discussed, not all of us may be knowing how to perform some of those procedures, be they examination procedures, diagnostic procedures, treatment procedures. And we wish to have an opportunity whereby maybe the glaucoma specialists or experienced senior doctors can be able to treat, go and train maybe in some seminars, in some workshops, the rest of the team, so that they can be able to use this guidelines well. And again, all these people mentioned here, the ministry, the NGOs, OSK itself, the private practitioners, could arrange for some of these training programs so that we can be able to be on the same table. We need a lot of advocacy and stakeholder engagement. These are really, we're talking about the hospitals, the people who run hospitals, the universities, and training programs, KMTC. So these are the stakeholders. So how can we ensure that these guidelines are understood? What is mentioned there is understood right from the beginning and is being used in the institutions where it's supposed to be implemented. Then we have talked about the research priorities. There are some research priorities we have listed, and I think that will go a long way in guiding what kind of research we need to do. So what are some of the main highlights in these guidelines? So I'm going to show some excerpts of that of the guidelines, just show some of the highlights that we have indicated there. So we have made many easy to read tables and illustrations. An example is shown here on table 11, the summary of methods of IOP measurement. So there are many methods of measuring IOPs, and whatever method that you're using in your clinic. So there's some explanation here, what it is and how it can be used. For example, we know that the Goldman applanation tonometry, the GAT of the Parkins, there is a gold standard for IOP measurements. But if you come like the eye care, that's the rebound tonometry, you can see there that it can measure IOP without the use of topical anesthesia, and it's useful for screening and for children. IOPs are compatible with GAT over a reasonable range. Not too low, not too high. So some of this will be the explanation. So if you have a method that you're using and you want to see what the guidelines say about this, you can refer to this table and it can guide you in understanding. So most of the highlighted are followed by concise recommendation. For example, if you talk about the important factors to consider when setting target pressure range, of course, we talk about the baseline IOP level before treatment, the stage of glaucoma, the status of the femoral eye, and the family history, and then other factors like CCT. So those are the important factors to consider when setting target pressure range. And again, now the recommendation down there goes that target pressure range is set per eye and needs to be reviewed and adjusted during each follow-up visit, depending on stability or change in structure and function of the optic nerve. So it's concisely indicated there about the importance of that target pressure. And the stress here also is that it should be measured per eye. You can't say that this individual should have a target pressure of 14. No, it's the left eye has a target pressure of 14 and the right eye has a target pressure of 14, because it's possible that the right eye probably has a target pressure of 18. So the target pressure is per eye. And so this, you can remind yourself using these guidelines like that. So then there are some tables like this, the staging of glaucomatous damage, which is very important. And patient you diagnose with glaucoma, first of all, you have to stage the glaucoma before you even do the, to set the target pressure. So then the suspect, early, moderate, and advanced, and you use the cup disc ratio. IOP is not very essential, and visual field can also be used. So if you want to stage your glaucoma and you're not very sure, and then you can refer to the guidelines and they can guide you about how to stage glaucoma. Again, a concise recommendation is given there about the staging of glaucoma, that each eye should be staged independently as suspect, early, moderate, or advanced glaucoma based on the optic nerve and or visual field exam about availability. As I said, visual field is good to have, but not as essential as the optic nerve exam. So you get something like the risk factors associated primary open glaucoma, we say is who is at risk of getting primary open glaucoma is people aged over 40, high intraocular pressure, African race, family history, myopia, and thin corneas. Again, recommendation down there, patients with 2 or more risk factors should be examined examined further for glaucoma. Again, this is something we have to know, especially when we are teaching that, or we are counseling patients, that these are the risk factors, and we need to be more careful when you have 2 more of these risk factors. There's a meta-analysis which has been shown there of IOP lowering effects of glaucoma drugs. Again, we have so many drugs, and when you see this percentage IOP lowerings that have indicated against these drugs, then you know which drugs you need to use at what time, and how low you expect your IOP to go when you use these drugs, so that you can see which drug should be first-line drugs, which drug can only be addition. For example, if you see a blinzoramide, it lowers pressure for only about 15 to 22%. So it's not advisable that you start with that as a first-line drug, but it's very effective when it's an addition to another drug that you have used, which is first-line. So we most likely recommend that the first-line drug will be either beta blocker like Timolol or a prostaglandin analog like bimatoprost, latanoprost, and travoprost. So I said that it would be great if these guidelines can be available in Word form, not in PDF, so that you can pick some of these tables. For example, there's a table here about settings of laser trabeculoplasty. You can have lasers in the procedure rooms, and you go there and you're trying to remember what are the settings if I want to do an LT or an SLT. So again, to make it easier, if this can be printed and be stuck on that the walls of the nose spot of the procedure rooms, then you can see, okay, I want to do SLT. These are the settings, the spot size, the duration, the power, the number of spots, and the area to be treated. So this becomes an SOP, and then becomes easy and straightforward, because, you know, so that people are not coming up with their own settings, which can either under-treat or over-treat. Then, of course, there's another one here for settings for laser peripheral iridotomy. Again, if you can put this in the procedure room, and then it becomes easy for somebody to quickly refer, and so that we are doing the same thing. Because sometimes you can do a different thing, and maybe you repeat it, and somebody else comes and learns from you and goes and does. At the end of the day, people are doing things completely different from the best practice. So if this thing is pinned there and is used as part of the SOPs in a unit, then we hope that we'll all be doing the same good thing. I mean, I'm stressing these SOPs so much because it's really key. If you're having a business, you know, we all know about aeroplanes. We don't see aeroplanes crashing all the time because of SOPs. Those people have learned the same thing and do it over and over again, and it's recommended as the best thing to do. So when it's done over and over again, it becomes so standard. So everybody does the same thing which has been recommended. And obviously that improves safety and effectiveness of the procedures we do. So we kind of thinking this, if we apply to glaucoma, which is a complicated disease with you know, various ways of treating, and if we can come nearer to having SOPs that can be used by various individuals, then we might be glad that we'll be doing the right thing. There's some pictures there, some illustrations about how some of these procedures are done, the iridotomies, the trabeculoplasties, and again, iridoplasty, especially where you should put your spots, and again, settings down there which can be printed and be put in the procedure room. There's a picture there that was contributed by Shir about the settings of goniotomy. It can be used to remind you how to set up your goniotomy. So what should we really be doing? Here we have the guidelines. They are nicely done, good illustrations, reviewed, and there we are. So what next? So first of all, I need to stress again the implementation. I need to stress about the ownership of this and how Dr. Gichangi's office is key in coordinating this usage of these guidelines, the dissemination that I've talked about, the training that I've talked about, the advocacy and stakeholder engagements that I've talked about, and the research priorities that I've talked about. So this is key. We cannot move on unless we look at this and see how each of us should be engaging in any of these implementation goals. And at the unit level, our wish is that we should update our knowledge in management of glaucoma through this guideline. So spend time going through the guideline, the document. It's easy, it's not very difficult to read, it's short. So just spend your time going through that and update your knowledge. And most importantly is that use these guidelines, set up the glaucoma SOPs in your clinics. And this is what I've been talking about all the time. The procedures I rated and those in the appendices could be utilized. In the appendices, you could see how to perform IOP, how to perform trabeculoplasty, how to do this and this, some of the diagnostic procedures or treatment procedures, which drugs do this, and what are the mechanism of action. So how do you pick which drugs to use at what time? And so if you're having SOPs in your unit, kindly allow these guidelines to guide you in how to revise those SOPs so that we can all be doing the same thing. It's just as simple as taking IOP. If people don't know how to take IOP, then they get it wrong. So if we can all be doing IOPs the same way, all of us, then we get it right. If you can doing the laser the same way all of us, then we get it right. If we can do any of the examinations the same way, or the treatment procedure the same way, when neotomy is the same way, then we all get it right. So I cannot overstress this fact that we need to utilize this and standardize the way we do our things. Then there are things like the patient information materials. I could wish that we institutionalize them, because we are all trying to make some patient education materials. Sometimes we also get from some drug companies which have made theirs from other places. You might find them were made in Australia and they've been transferred here. And what the patient sees or when the patient hears or reads, it really doesn't appeal to them, or it's not practical to them. But the patient information material we have put there is standard and is more applicable to our country. So what I would advise is that you go to those guidelines, get that patient information materials, put a logo of your hospital, of your clinic, or the university, or wherever you are, and call them yours. And the OSK itself can do it. And if a drug company wants to give you some patient information material about glaucoma to distribute, tell them, why don't you use the ones in the guidelines? If you want to call them your name, if you want to put your drug there, that's fine. But we want the patient to have the information that has been looked at by all these people have contributed, because they understand what they want to tell the patients about glaucoma. So let's use that patient information materials correctly and utilize them because they are considered the gold standard for Kenya at the moment. So in conclusion, this guideline recognizes the various skills levels and equipment currently available in the country. It's our hope that all cadres of human resources for eye health involved in glaucoma management will find them useful in their day-to-day work. They should have a note to replace textbooks and journals as source of more detailed information, nor should they discourage innovation in the day-to-day care of the patients. The final responsibility in the decision-making in the treatment of patients lies in the eye care personnel involved, and the guidelines, as the name suggests, can only guide. Thank you very much. We should acknowledge Dr. Michael Gichangi, who has been very effective in working with the OSU team and the Ministry of Health in producing this. Want to acknowledge Professor Karim Damchi, who actually initiated the first guidelines, even used his own money to enable us to meet initially. People traveled from various countries to come and meet in Nairobi and start preparing the first draft where, they've been improved until now. All the contributors that I've talked about above and the others and the viewers, and thank you for listening.